This 3D animated diagram shows the body's hidden lymphatic network. When lymph nodes are damaged by surgery or radiation, they act like blocked toll booths on a highway. Fluid backs up, causing the severe tissue swelling known as lymphedema. To reroute that fluid, you have to apply exactly 30 to 40 millimeters of mercury in pressure directly on the skin. Firm, precise. You are stretching the surface layer, not pressing down into the deep muscle. You also have to match the natural biological pumping rhythm of the vessels. That means executing one stretch and release stroke every 2 seconds, repeating the motion 15 times per zone. Because this technique actively moves fluid into the bloodstream, it must never be performed if you have an active cellulitis infection, deep vein thrombosis, or unmanaged congestive heart failure. If you are safe to proceed, the sequence always starts with deep diaphragmatic breathing. Expanding the abdomen activates the thoracic duct and cisterna chyli, creating a central vacuum that pulls fluid toward the core. By combining specific skin traction, exact pacing, and that deep abdominal vacuum, you prepare the body's healthy pathways to safely receive the redirected fluid. This diagram shows the rerouting strategy for a compromised left arm. Because local nodes are blocked, fluid pumps across the chest to the healthy right armpit and left groin. To get fluid there, clear the nearest exit first, the shoulder, before sweeping up the arm. The elbow often acts as a physiologic bottleneck where lymphatic vessels narrow and traffic jams occur. If the swelling has caused hardened, fibrotic tissue here, you apply targeted, deeper C-strokes to break up the congestion. Once the upper arm and elbow are clear, you progress distally. The strokes move down through the forearm, across the palm, and finally trace each individual finger from the nail bed down to the base. Clearing the proximal exits before pushing the distal fluid ensures the newly mobilized fluid actually has an open pathway to drain into, rather than compounding the blockage. This supine map demonstrates lower body drainage. The process initiates with clockwise strokes across the abdomen, preparing the primary inguinal and popliteal nodes. The sequence then marches down the leg, clearing the thigh, the popliteal nodes, the calf, and concluding at the foot. When dealing with lymphedema in the genital or pelvic region, positioning is critical. You must elevate the pelvis on a folded blanket or pillow to utilize gravity as a secondary pump. This diagram of the pelvic region shows the required stroke patterns. You execute curved rainbow strokes to push fluid outward, away from the pubic midline, and then sweep it straight up the lateral sides of the trunk toward the armpits. By manipulating gravity and specifically targeting these lateral-collateral pathways, severe pelvic congestion becomes a systematic, solvable problem. Reaching the fingers or toes does not end the session. The universal rule of lymphatic drainage requires you to perform the entire sequence in reverse, working stroke by stroke back to the core. You then execute a final round of deep diaphragmatic breathing. This completes the central clearance loop, pulling the last mobilized fluid through the thoracic duct. This animated diagram illustrates the critical vulnerability of the treatment. Manual drainage successfully removes the fluid, but it is only a temporary shift unless the tissue is immediately sealed with compression bandaging. During initial treatment, short stretch bandages are worn 23 hours a day. Once the swelling stabilizes, you transition to a medical-grade maintenance garment that provides a constant 40 to 80 millimeters of mercury in pressure. True lymphedema management requires combining precise physiological rerouting with rigorous structural compression. Together, they allow you to permanently command the body's fluid traffic.